Well, we do appreciate all that you've been doing, and we are proud to be associated with you. I told some
Thank you.
people 15 minutes ago who got on the call a little early that at the board meeting yesterday, we paid great tribute to you, but you
That
also
was
paid
nice.
tribute to your staff who are running the hospital while you're getting the messaging out. So thank you for making time for this conversation today.
It's an important one.
Obviously, we have a lot of United Methodists on. I extended the invitation to many of our ecumenical partners as well. So
Wonderful.
this is really aimed at church leaders for you know, how to cope with this. And let me just start off with a question. Where are we in our battle against COVID-19? Can you give us a general summary of what things look like at this point?
Sure, and I have slides at some point that can show you some of the data around that, but you know, right now is a challenging time. There's no question. That's why, you know, as we were talking briefly, things have been a little crazy. You know, the hospital, so you know, there's a lot of very conflicting messaging happening right now, and it's very frustrating for everybody. I get it, and believe me, it's frustrating for us. So, you know, you get the kind of, oh my gosh, the sky's falling down, this instant sort of, you know, theme, and you get others who still are, oh, this isn't that big a deal. And of course, neither one of those are right. It's in between those, although frankly, it's more towards a level of concern than, you know, the people who are saying, well, this is nothing. We're seeing this ramp up very significantly. We at the hospitals have been trying to find the right messaging, and the Texas Medical Center took a little misstep last night and ended up kind of messaging that, you know, we're full and we're about to be out of control, when really that wasn't the case. It was really intended to rally people, and then they kind of mismessaged it, rally people to do the right things. So this morning, actually, 4 of us did a press conference to talk about hospital capacity. I'd say that the key messages from that, if I was to summarize, is we all have hospital capacity and have lots of creative things we can do. So we are not in a today shortage of hospital capacity. We have creative things we can do, but those creative things only last so long. So, you know, in 2 to 3 weeks, if we stay on a trend line, we're going to start to have some real challenges. We know that we can change things in the community with a 2 week or so lead time and bring the curve down. And so the time now is to start taking much more definitive actions, all of us as citizens, and other things that we need to do. And that's the time, you know, to do that now. So that was a second big message. The third is really everybody personally, individually needs to do the social distancing, the hand hygiene. You know, this is not the time to advance through the society, new things and new openings, because right now this virus is going up very rapidly.
Let me just sort of launch in with what some pastors want to think about as we lead congregations. And one pastor I talked to earlier today had this question. He had led a rather large church, one of our largest United Methodist churches, into a slow response, and they have not yet started worshiping in person. Reopening is sort of the catchphrase for that. But they were looking at doing so the second Sunday in July. If you haven't started in-person worship, should you delay farther? And if so, how long?
Well, unequivocally, you know, I don't think now is the time to march forward. So, you know, if where you are, think about whether you need to go backwards, and I'll talk about that in a second, but definitely I would say now is not a time to move forward with loosening of any sorts of behaviors or restrictions or practices or, you know, worship services, anything that you're planning. So that second Sunday in July, that's within about a 2 week time period of now, right? 2.5 weeks, I guess. And that's really within, I mean, the way things are looking right now, best case scenario, we're at peak, then we may still not be quite at peak. So we're on the way up. We haven't gotten back to the way down. You know, even if somebody's planning that and going through all the, you know, the details of planning that now, I would find it hard to believe that when that date rolls around, they're going to go ahead and execute on that plan, just from the numbers I'm seeing right now.
Wow. Okay.
And now I'm talking, you know, now let's keep in mind, I know this is a broad-based group. So let me clarify, I'm talking about, an urban area like the greater Houston area where we're seeing a major outbreak. Obviously, some people may be in different towns, smaller towns, where they're not seeing that outbreak. So they need to be paying attention to what's happening in their area. But if you're talking somebody kind of in this greater Houston area right now, we are seeing very, very significant community spread. We've seen hospitalizations triple since Memorial Day. We're in control. We can handle it. We have some runway to continue to increase, probably at least double if we need to, without, really having to turn everything else off that's happening at the hospital like we did last time. But, that's 2 weeks to 3 weeks out. So we need to be careful that if there's something planned in that near term, not to go there. And we've seen messages, as I said, swing a little too far both ways. But, if you're sort of thinking of the pendulum of, I don't need to be concerned at all. And, maybe this is mid-May and things seem to be going well and things, haven't been increasing and you're towards there. Or if you're thinking about how you felt kind of around the beginning of April, end of March, you should be feeling a lot more like end of March, beginning of April. You should be feeling a lot more like end of March, beginning of April right now. We're at a much higher peak than we were then, and we're not peaked yet. The people who are in the hospitals tend to be younger. They are staying a shorter time. They're not dying as much. They aren't needing as many ICUs, which are all wonderful things. And I'm happy to talk about why that is. But the bottom line is, for example, take Methodist. We got 330 something patients in-house right now. We peaked at 207 in April. And across the Texas Medical Center, we're probably in the 1,600, 1,700 patients. Back in the mid-May, we were at 500. So way more than triple at this point in time. So again, now's a time where really things are at risk of slipping out of our control.
So if we were to say, okay, we're going to give up on the second Sunday in July option, what's a fallback? When might we think about it actually being okay to reopen with all the precautions we're talking about?
Bishop, I wish I knew the answer to that. This curve is different than the last curve because of all those things I just said in terms of the number of people getting hospitalized, the age range that's happening, the shorter lengths of stay. So there's a lot of good things happening there, but it's also different in that we are seeing far more people diagnosed in the community. So, that's bad news. The good news is even with far more people that diagnose, we're not seeing, that big of an increase. We're seeing a big increase, but not proportionate in terms of hospitalization. So clearly a younger group, they're not doing as poorly. Some people ask, well, did the virus change? We don't find any evidence of that. The jury's out on that. I can't give you a definitive answer. We know treatments improved. There's a lot of other things going on like that, but this is a different curve. And so we don't understand it as well. It's going up very rapidly right now. Again, not with the kinds of mortality risk that we saw. Now keep in mind, you're still seeing patients die, but not quite at the rates we saw before. And so I'm just not sure exactly, but I think if you went back to kind of where we were at the end of March, you'd be sitting there, saying, don't know when this peak's gonna end. And it ended about 2 weeks later. I think that's probably our best case scenario right now. We haven't done anything as a community nearly as definitive as last time. We've been trying to figure out how to do this without that, because frankly, if we can do this at hospitals throughout the community for months and keep patients safe and keep our employees safe, it is doable. So in theory, the things you're talking about in a church setting are very doable and safe, but at a point where things are going down, not where things are going up, would be my advice. So, if you'd asked me 4 weeks ago, we'd have said, yeah, and actually I had that conversation with a number of your local ministers here to say, yeah, start easing things. And a number of them started to do that in July, and or June. That was perfectly reasonable. It's just a different scenario now as we look at the numbers.
Did I understand you to say you don't think we should be going backwards though?
Well, I think that's a congregation by congregation kind of choice. Let me put it this way. So the governor gave the authority to the county judge now to limit gatherings of anything greater than 100. It's not clear to me, honestly, if that's going to apply to houses of worship or not. But that's a distinction politically, not a distinction, in virus terms. Certainly if you've eased to the point that you're doing large gatherings that are much bigger than that, yeah, I think you should be thinking about whether you back off. Now, if you've got 1,500, 2,000 person, church and are able to, have in your sanctuary that, people really spread out there, that may be more equivalent to having, a group of 20 and another group of 20, if you think about how some of those people are arranged. So I don't say that with 100%, but by and large, I would say if you're getting into those numbers, you need to be thinking about ramping back. I mean, within the hospital, we still don't let anybody gather in a group greater than 10. Unless it's a clinical situation where they have to, but certainly no business administrative, non-clinical situations where people are getting together and gathering like that, because we're being, extra safe and extra cautious. I know this isn't the news everybody wanted to hear today, but unfortunately the virus has had some different ideas right now and is going a little bit the wrong direction in Greater Houston again, and in Dallas and in Austin and in San Antonio. And what we saw this morning was the governor started to restrict elective surgeries again in Austin, Travis, Bexar, and Harris counties. So the core counties of each of those urban areas now have some restrictions going into effect on Friday night. They're different than the last. We'll be able to still do some outpatient procedures and other things that don't hurt our ability to take care of COVID patients, but there will be some things that we will have to start turning off in order to handle the volumes of COVID.
If a church is worshiping in person, what are the things that you think they ought to be making sure of in order to be as safe as possible, given that decision that they've made?
Sure. So I'll start with highly discouraging anyone with a vulnerability from being one of those worshipers, in-person worshipers. They need to worship virtually. So you got to look, and I know this is a tough one to talk about, but you got to look at age, and you got to say, at some threshold of 60 or 65, the numbers start to go up in terms of risk, and we really should try to keep those individuals from coming in. Particularly those individuals who have underlying medical conditions, and those don't have to be dramatic medical conditions. They may be hypertension. Hypertension's been a big one. Some heart disease, lung disease. Many other things. And younger people who have some of those conditions. So if you've got a 45-year-old diabetic, they probably shouldn't be coming to in-person worship service at this point. Those are the people we need to be, isolating and protecting at home, and then reaching out to them spiritually and emotionally and as friends and colleagues and loved ones, through other means, virtual means, and helping them in other ways. So that would be step number one. Step number two, for a younger, healthier crowd. Now, the flip side there is, what we've seen is, I think, a large part of what we're doing, while it is getting blamed, at least politically on one side, and all the reopenings. And, let's face it, the reopenings clearly did allow the virus to increase. We know that. But I think, to me, watching the data, the biggest uptick really came around timing, where personal behaviors really started to slip. People got, they saw 3-4 weeks of, hey, this wasn't so bad. We've been reopening. The data's not going up in May. Oh, hey, now it's Memorial Day. Let me crowd into a pool and let me go to a party. And, it's summer, and let's the kids all start having their parties. And we've seen all of those kinds of things, I think, start to bite us and start to get us, and are starting to bump things up. Some of that was compounded by, obviously very understandable, but nonetheless, from a virus perspective, troublesome large protests, because, in a viral time, we're talking about 100 or even 25 here, to put 60,000 people together, is a real challenge from this virus time. Looking at the data, nobody can prove what I'm saying. Okay, this is my take on the data. I don't think that was, the major factor. It was a factor. I think there was and that was 60,000 people. We have 7 million people in Houston. And I think it's pretty fair to say, from the behaviors and the things I've seen when, I'm out in the community, and I don't go out much, but if I've driven by and looked at things, I haven't been to a restaurant, I've picked up. I haven't gone out to a restaurant yet. But when I see some of those behaviors there, I got to figure 20, 30, 40% of the population has been too lackadaisical. So that's, couple million people, and doing that day in, day out. So at the end of the day, I think those were a bigger impact than the marches. So what I was going to say is, keep in mind that some of your younger people have been some of the people who may not have always been the ones following guidance as clearly. And I'm getting kind of countless stories from people who contacted me needing testing of, hey, my kids who are 25 were at a party, and then this kid infected that kid, or, you know, we exposed that kid, and then they came home to my house. So we're seeing a lot of those kinds of things. So just be mindful of that. So you really need to think about the messaging that says, if there's a shadow of a doubt, you've had any sort of potential exposure, you don't feel well, you feel a little run down, you have a scratchy throat, you know, you are having a cough, you've started having a fever, you know, whatever those things are, if in doubt, just stay home this morning, worship with us virtually, don't come. So you want to have people come, you know, that's not a perfect measure by any stretch. You know, I think you should ask people that very firmly. You know, these are houses of worship. I hope people would, you know, obviously follow that. And also you could look them in the eye and say, yep, I'm following that. So I don't think you need to put temperature screening in. You can, but I don't think you need to do that. I do think you should bring people in through one set of one entrance probably, and through another exit. So you just kind of don't have all that, you know, traffic and those people getting too close. You need to focus on social distancing. You know, in a Sunday school class, which might be a pretty small, you know, classroom, right, within a church/school setting or something like that, you know, be really mindful of the size of those, because those are pretty small rooms. So, you know, you need to really think about, can you take those outside? It's hard in Houston this time of year. Is there a bigger setting those could meet, and meet, you know, with some distancing, everyone wearing a mask, from, you know, the actual worship service standpoint? How do you keep it down and, you know, keep a family unit together, and then keep great distance between them? Enhanced cleaning protocols. I mean, all of those would be the things to continue on. If you've been doing it safely, I mean, you've now got a few weeks of experience, and you've not been, you know, having congregants call you and say, hey, I came to church and I was sick, and you've not been doing a bunch of tracing of other people, or someone calling, or the county health department calling and saying, we think this person might have gotten this there. You know, that says you've probably been able to do it safely. You've been doing it safely at a point where the virus was at a lower level in the community, and now it's at a higher level in the community. So there's a caveat with what I'm saying here, but you've been doing that safely. You know, I think you've got to be extra vigilant, but I think if you don't let your guard down, I think it would not be unreasonable to say, let's try to do similar things. Now, you know, there's very active discussion, and there's a lot of politics, but very active discussion, you know, between local health officials and state health officials. And this whole question of, do we need another shutdown? Will there be another shutdown? What else needs to be ramped back? I don't have any idea, frankly, where that will go. But it is distinctly possible in some time frame, you know, anywhere from soon to the next 3 weeks, that we end up in a shutdown or an effective shutdown in Houston. I don't know that for a fact. I really personally think that if everybody did their part, we could avoid that. But you know, we as a people, we as, you know, the 7 million people in Greater Houston have not shown that we're able to do that. I mean, it just, be blunt. You know, we have not shown that to a T, everybody can look each other in the eye, link arms, and say, we gotcha, and do it correctly and do it together. And it doesn't take a lot of kinks in the armor to sort of blow that up for the whole community. And that's really, frankly, where we are today.
What about singing, congregational singing in worship? Is that even something that could be thought about, or should we just abandon it for a while?
You know, that's always part of my favorite part of the service. So after the sermon, of course, but you know, that is, yeah, it took you a second. And that's a no, I'm sorry. But, you know, the data that's out there, you know, says that when we are speaking loudly, we are projecting, and there is a greater force. You're going to probably spread some of the droplets farther, even with a mask. A mask helps tremendously. But the idea of having a bunch of people there singing is just, I just don't think it's a good idea. I mean, you know, a performer up front, you know, one individual who's well away from everybody. I mean, well away from everybody, probably masked, which is hard if you're singing, you know, is an option. Obviously, you know, people playing musical instruments, but I know there's some issues where you can't put too many people with a wind instrument together and those kinds of things. But, you know, a string quartet or things like that, if that's something that's in a budget and able, there may be some other ways to worship. Obviously the organ, but the actual singing of hymns and things, I think is a bad idea. And choirs are a terrible idea. I mean, I just don't think no one believes that's safe right now. It just is. I'm sorry. I don't like the message, but it's don't shoot the messenger. So please.
No, I'm going to interrupt a minute though and ask, because you said something there that really ticked me. Not just really tickled my brain. When you said a single performer well away, what do you mean by well away? And masked? Well away and masked?
Well, okay, if we think about the 6 foot, the 6 foot rule we have for kind of normal interactions is pretty well data driven. Nothing, I mean, let's be clear. We still don't know everything about this virus. Not everything's known. But we do know that most droplets would drop out of the air before 6 feet. Put a mask on, of course, and you've cut the number of droplets pretty dramatically, but there's still some getting through. Okay, I mean, and the virus itself does not generally get blocked by non N95 masks. It's the fact of the matter is the virus is in droplets, and droplets are easy to catch. And I don't mean droplets as in I'm talking and I see spittle flying. I'm talking much smaller than that, but still very microscopic actually, but much bigger than the holes in the mask, so they get caught by the masks. But things can bend around the sides of the mask, so you're not perfectly protected, right? But masks are also then something that help us get a little closer to each other. I mean, clinical environment, right? We know that we need to care for patients, and to care for someone, we need to be very close to them many times. So it protects the patient, it protects the caregiver. So it's not a license to get close together, but it certainly helps with those moments of time. That's why, particularly when people are walking through a supermarket and they're going to pass by each other in an aisle and all those kinds of things, you really, really want those masks on. So then you get to the singer. So the singer is going to, I've not seen data on this. I'm sure there is, but it's not going to be 6 feet, right? They're projecting. I mean, a beautiful voice is loud, it amplifies, it projects, and I'm guessing, total guess, you're talking 2-3x the kinds of distances in terms of potential droplets. Now again, you can block the majority of that with a mask. So if I had an individual like that I wanted to have sing in a worship service, I'd figure out how to put them up on the, right, not I mean, if you've got the preacher on one end at the pulpit, whatever your room is, you've got your stairs up there or your tiers there for your choir, go stick them back up there, and have them be pretty distanced. I don't have a perfect answer for you, but most of those, if you're not talking a tiny little church, good 20-25 feet, something like that. If you're going to do something like that, obviously there's some smaller churches that may not be able to do that, in which case I probably wouldn't go with that. Again, I've not seen a study on that that's really definitive. I'm just giving you some common sense advice based on what I know. So.
Well, we respect your advice and are grateful for you sharing it, and we will not hold you accountable for that, because we know you're giving us your best information in a rapidly changing situation. Let me turn to another question that's been sent in. What do we know about herd immunity associated with COVID-19 right now?
Yeah, it's a great question. Lots of we don't know yet that I'm going to give you, but I'll try and give you as much data as I can. So we do know that in monkeys, when they study it, that when you get the virus, you form antibodies, and those antibodies neutralize the virus in a test tube kind of situation. We know that with monkeys, when we give them a vaccine, with a couple of the candidates, we can do the same. We give them enough antibodies, and those antibodies will neutralize the virus. We know that in patients where we are trying to treat with convalescent plasma, that when we get somebody who's been cured of the disease, they're 3-4 weeks out, we draw their plasma has a bunch of antibodies in it. We take those antibodies, we put them in a test tube, we know they neutralize the virus. So we have, and we know the preliminary studies on several now of the vaccine candidates have been, cause for optimism. They've been safe in a very small population of people, so the safety, that's not answered yet. But they have actually been, it appears, effective, at least in generating the antibody response. So we have reason to believe, I think with most evidence that says there is immunity. We have no idea how long that immunity lasts. Could it be 3 months? And there are some viruses that are like that. Could it be lifelong? I doubt it with this type of virus, but it's possible. Is it a couple of years? Some of the best guesses we're kind of hearing from some of the scientists and the vaccine companies is that they're thinking maybe every 2-3 year booster, but not annually like the flu. And we're not seeing this mutate at the rate like the flu, where you would need something and something new evolves. So by and large, herd immunity should be achievable. It may take, every 3-year vaccinations till this thing's gone. I mean, if you got one really good round of herd immunity, you could get rid of this thing. But, a lot of people think this may become more seasonal, but, okay, we do lots of things where we give boosters and things. So then you get into the question of how does one develop herd immunity? There's really two choices. One is enough people get sick and they develop the antibody and they get herd immunity. The other is we give it to them through a vaccine. The vaccine is maybe we end up having some vaccines in the fall that start going into large scale safety and efficacy trials. So those will be volunteers who want to take them, and first in line are going to be a lot of healthcare workers for obvious reasons. And so it's not inconceivable that at least hundreds of thousands of people in the U.S. may get a vaccine. But of course, there's 300 million people in the fall. But really, the real amplification of that would be in the spring. The Trump administration has Operation Warp Speed. They are plowing money into this issue. Normally, it's a very linear, sequential, kind of Gantt chart approach where you do this and then do this, and next thing you know, it's taking you 15 years. And they're parallel processing everything. The biggest one of those is actually building the manufacturing capacity now. So they're building manufacturing capacity that may never get used because those vaccine candidates fail. So it's a financial gamble now to try to obviously move this faster. It's the right thing to do. And that's the beauty, of government, and particularly at the federal level, stepping in, is that's where you make an investment for the long term. So from a vaccine basis, we're talking well into next year, probably this time next year at least, before you could get to enough people immunized. It doesn't mean you might not be able to start bringing it down and attenuating it, but to actually stop it, I think you're talking about a year to get to herd immunity. Now, herd immunity can also be developed by getting the disease. And of course, the combination of those two can work too. So it could be that we have enough people who've gotten it, and then we have the vaccine and we have a shorter distance to go to get to herd immunity. That's a challenging one. There's been a lot of debate. There's been a lot of discussion. The country of Sweden has been held out by kind of both ends of the argument. If you look at the data, the country of Sweden did not shut down to the degree of the rest of Europe, although they did do many things like restaurants. And if you go to the vacation sites there, the hotels were down 95%. So people did a lot of the same things even without a government order. Their mortality rate is markedly higher than their neighbors. Now, it's not so much higher that it's, New York. And so the challenge with that discussion is most societies, especially as politicized as they are, seem unable to have the decision and the discussion around those kinds of ethical and moral trade-offs, which is, at what point is there, I'm going to be blunt, but ethically and morally, at what point can we accept a certain level of death and suffering and illness, weighed against, what happens to the rest of the population with the financial side and with health issues that happen because of a shutdown and all those. And so it's tough to draw an absolute conclusion, but I can tell you it's been a disappointing experiment for them. Personally, I don't think it was a good way to go, but with them doing it, it's been a disappointing experiment because when they've looked at the number of people who have immunity, at least supposedly through antibodies, it's in the 6, 7, 8% range, and yet they've already had very large number of deaths. And so you do the math, and they're going to have a very high mortality rate. So put it another way, New York City, last I looked a couple weeks ago, they were over 260 deaths per 100,000 people who live in New York City. To put that in perspective, the US in 2017 had, 850-ish deaths per 100,000 people for the year. Heart disease was number one, right under 200. You've of course got cancer and a few other things I think cancer is 150, 160, 260 for COVID in 2 months. So in 2 months, it had a mortality rate that was well above the number one cause of mortality in New York. And if you're generous and do some of the studies, the absolute highest number of herd immunity, it's not herd yet, but immunity trying to work towards herd, the best bet, the highest bet that you could get is about 20%. That's probably an overestimate, but the highest bet would be about 20%. To get to herd immunity, you need 60%. So if nothing changed, you would need to triple 260 to, your math of tripling 260, which is 780, right? Or whatever I'm doing, 680, 780, I've got it. That's almost a full year's worth of mortality from other things. Now, they could probably do better than that because they were totally out of control and they could let herd immunity go. But when we did the analysis, best case, 450, 500 people per 100,000 dead in New York City to get to a theoretical herd immunity, which would basically raise the death rate by over 50% in the city. That's not ethically, morally, to me, a trade-off that can be made. So it's a long-winded answer to a complex question, but to say our real hope for that is a vaccine, and I don't think practically we're going to get there. And if we have to get there by this going through the community, it's going to be because we never got a vaccine, or the vaccine proves to be more difficult. And a lot of people are going to suffer and die to get there, I think.
Here's a question about symptoms. We hear a lot about symptomatic and asymptomatic people, but is there much in between? Can a person be mildly symptomatic with just one small symptom, or is that unlikely? Couple that with the question that, as a senior pastor of a church, or me as leading a conference staff, what if one of my team is mildly symptomatic? Do we keep them at home?
So anyone with any level of symptoms at this point, you should assume COVID until proven otherwise. So yes, if you have some mild symptoms, stay home, get in contact with your physician, get some virtual urgent care, use some mechanism to be discussing that with a physician. They may or may not decide right away to do a test. It may be, hey, let's just keep you home for a day or two, see where this goes and test you, or they may do the test. The good news now is we have such significant testing capability, they'll probably do the test. That's what I would do clinically, and I still see a few patients. And I've had a bunch who've needed testing and a few who've been positive. We think, best guess, and the CDC uses this in their modeling, 35% asymptomatic. If you really drill into that, probably some percentage of those people are really very mildly, but if you really check, they might have had some mild, but very mild symptoms. And some small percentage above that are mild. So yes, there is a full spectrum of disease from barely, asymptomatic, barely symptomatic to, yeah, it was a couple days of having a bad cold, to I felt like, a truck ran over me for a few days, just like when I had the flu, to I couldn't breathe and it felt like somebody was squeezing my chest and I had high fever. And I went to the hospital and, they had to use every technique they could to keep me from getting intubated. And, to I got intubated and, went through, or to I got intubated and my body went into this cytokine storm that we talk about. It's not well understood who goes where and how to predict that. I think we've gotten better at that with some of the inflammatory markers. So, we have seen the outcomes improve dramatically at the hospitals. A big part of that may be some age shift, but I don't think it's all age shift. I think we've just, our doctors are smart people and, very academically oriented and, have gained the experience of treating, it's going to be 2,000 people pretty soon in the hospital that we've had, over the course of 100, 110 days. Learning matters. And at the beginning, everybody just, had not ever seen a person with COVID before.
What factors do you attribute to African Americans dying at disproportionately higher rates than other ethnic groups? Additionally, does the Texas Medical Center and Houston Methodist have a plan to address these healthcare inequities and disparities?
A great question. So we do see both socioeconomic factors and race as factors alone in terms of risk. So the African-American community has a higher burden of disease and therefore higher burden of death, on a per capita kind of basis. It looks like, so initially we were hearing lots of data that it was both more people getting sick and people doing worse. I think most of the data is suggesting it's the first part, not so much the second part. So there was a large study out of New Orleans, out of Ochsner a month ago or so, looked at a couple thousand, 1,700, 2,000 people, saw no difference in mortality by race once people were in the hospital, which is obviously great news. But if you took 1,000 African Americans, you were having more African Americans die from the disease because a higher proportion of the African Americans were getting the disease, and therefore, even with the same death rate, of course, there are more deaths. We've seen the exact same data. In fact, even lower mortality, but we've seen very similar data at Houston Methodist. So if I went back kind of through wave one, 34% of our admissions were patients who were African American. That's about 20% across the 8 county, it varies by county, but roughly about 20% of the population. So that's a very disproportionate number. We actually saw significantly lower mortality. So at least in our numbers, if you did the math, it really wasn't too much extra death, which obviously great. I don't have a great explanation for why that was. It could be that knowing that there was a lot of data out there in African Americans, we may have been more conservative in admitting some, very much. Our clinicians are obviously very sensitive to every potential risk factors, and certainly socioeconomic factors, racial factors, and others that might play into a disease and cause a person, there's drugs that work in whites better than blacks. There are diseases that happen, in people of different genetic descent. So that's always part of what we think of as a clinician to help people. And so I don't know if perhaps something like that happened. We've actually seen that come down. So what we're seeing now is our African-American population is down about, I think the last number I saw was 28%, which means in this wave, it's actually been not quite, but almost down at sort of the expected number from the population. What we've seen is a marked increase in people of Hispanic descent. It was about 25% in wave 1. Now it's 50%. We're seeing a lot of those individuals who speak limited to no English. Our caseworkers and people on the front line are saying we all need to work together to do a better job messaging in Spanish media and many, Spanish churches, many realms to get to people who don't have English as a first language or who don't speak English at all. Because we're hearing from some of those patients, well, no one told me, I didn't hear these things. And, a lot of those community have been people, sometimes we're talking to our caseworkers, our social workers, talking to them, and they work 2-3 jobs. And they're, very frontline jobs where they're exposed to many other people. So long-winded answer to kind of give you this scenario of where we are. Whether there's genetic factors is very, very unclear. We do know that certain antihypertensives work differently across races, and ACE inhibitors are actually one where, I'm an internist, so it's always on the boards in terms of different races act a little differently in terms of how effective ACE inhibitors might be. And I raise that because the ACE2 receptor in the lungs is actually where the virus binds. So it's possible there may be some, genetic differences that are explaining it. But honestly, I think most of it has to do with socioeconomic status across different communities. Probably not all, but I think most of it is that. So the next part of the question then is, how are we all trying to work? So there's a variety of things to that. Part of that is messaging, right? So we need to get communication out to people, of every part of our community, everywhere in our community. The faith institutions are critically important for that. So thank you for being on these calls. It really helps. And of course, the Methodist Church, and I know we have others as well. I mean, you touch so many aspects of our community, broadly. So that is critically important. We've worked very closely with a lot of our, what we call community benefit partners. So we have a number of federally qualified health centers and community health centers and others that we fund every year. So we're kind of on our community benefits people are kind of on a hotline with them, working with them, trying to do things. We've worked very actively with Harris Health, which is the county hospital safety net system, for a long time. We still do. We've been very early. We could only get a little bit, and then later we're doing much of their testing. So we're able to help them with a lot of testing going through some of their clinics, and especially at their hospitals and testing. But I think there's more that we're going to need to figure out how to do, quite honestly.
Related to that, is there something about type A blood being worse in terms of impact? Is that another genetic or biological factor that makes some people get a more serious case than others?
Yeah, I have type A blood, and I'm A positive. So I always tell my wife that means I'm an A plus, and she rolls her eyes at me. So that's how I remember. Yeah, I didn't like reading those data. There is a suggestion that type A blood people with type A blood do a little worse with the virus, and that people with type O blood are on the other end of the spectrum doing a little bit better. There is some data and some theory that honestly I've not delved into that to understand the science behind some of that, but there is a little science behind that makes that at least have some plausibility. It is not to the degree that people come in and we say, hey, let's blood type you to figure out, are you at risk or not risk? I mean, we might blood type you if we're going to give you convalescent plasma, because we have to match to do that. So And it's not anything any of us can change. So, you know, as I joke, I'm A positive. It's not something I walk around worrying about saying, hey, I've got type A blood, I'm at higher risk. I think, you know, the fact that I'm in my mid 50s is probably a much higher risk factor for me. And, you know, not as much if I was 10 or 15 or 20 years older, but that's much more of a risk factor than, you know, being type A. And if I had diabetes or something else, that's much more of a risk factor than blood type, most likely.
Since you just mentioned age is a key factor, what if the pastor of a church is the one who's over 60?
Well,
what precautions should an older pastor take? I'm 66 as bishop. What advice do you have for those of us who are in that 65 and older group?
Sure. So, you know, what we see is that mortality really does trend with age. By far the highest risk group is 80 and up. Our in-house mortality, so this is not everybody who gets the disease. This is everybody who's sick enough to get admitted to the hospital. In wave one was about 35% for people above 80. Now, I put a caveat there that some, you know, we get some patients from a nursing home, some people with advanced dementia, they have advanced directives in place. So, you know, if that individual were to get the flu in a normal winter, they probably would die from the flu. You know, so, you know, a lot of those people may have gone straight to comfort measures. So just keep that a little bit in mind, so that doesn't inflate the number of deaths, of course, but it just is, we have a population where we don't pull out all the stops because that was their wishes. But so it gets particularly high there. The good news is even that's coming down now during this second wave. So we're down to about 27% in that population. So the whole mortality curve is shifting, which is why I think it's not just a younger population as we see things. But you start getting into 6+%, I'd have to pull up the numbers, you know, but range. So that's for who gets admitted. Let me be real clear. So many people at 60 can get the disease and don't get admitted. So it's not to say 6% chance of dying if you get the disease. But once you get hospitalized, about 6% of patients in that age group, roughly, are dying. So, you know, if you're 66 and you have a list that long of health problems, you probably don't need to be serving as the pastor, seeing a lot of your you know, your congregation in person. You know, at 66, if you are pretty healthy, you know, I think there are ways to do that. You just have to be extra safe. You know, some of you may have been on some of our town halls. We do. Dirk Sossman, he won't mind I say this because he said it in the setting. Dirk is my chief academic officer. He's fabulous. He's 72 years old. And, you know, we sat there and people asked us all these questions and I'm talking about how I'm protecting my, you know, approximately 80-year-old parents. And he chimes in and says, well, I'm 72 and I'm here sitting next to Mark, you know, in this town hall. We were masked when we needed to be, but you know, he can do that safely because he knows all the best practices. So I think if you're a healthy mid 60s to 70, you know, you got to acknowledge there's some risk, but I think you can find ways to do that safely. I mean, if somebody was, you know, preaching and serving way past that, you have to start thinking twice about that.
You've raised significant concerns about Harris County and the greater Houston area. What are your insights about Beaumont area or Tyler or College Station communities that are in the 40 to 120,000 population range?
Well, I'm going to have to apologize that I have not looked at any of their data, so I do not know the prevalence there. I know each of the counties reports that. One of the places I like to go, if you Google kind of New York Times, COVID, Texas, you can get statewide data by county. It's a pretty good site and it gets updated pretty much daily. And you can actually then get some data in terms of how many cases per 100,000 people are in a county. Put that in perspective, Harris County is probably at about 7 right now. So again, remember that's 7, and not cases, I'm sorry, it's deaths. But we're at 7 per 100,000 in deaths. So put that in perspective, 850 a year. So, you know, maybe 1% extra mortality if all of those people might not have passed away. And some of those, you know, the older person that was comfort measures only already might have died during the year. So that may even overstate a little. But of course, we weren't through this yet. But, you know, compared to 260 in New York, we've done really, really well. I don't have the number per 100,000 committed to memory in terms of the caseload, but you can pull both of those there. You can sort it by counties, and then I would pay attention to what your county is saying in terms of the prevalence. I just don't know. We have seen overall a good trend of, a good trend for if you're in a smaller community, that the smaller the community, the less spread there is, the less, there is some spread associated with density of population. Now, there are some smaller counties in North Texas, particularly with meatpacking plants that have had major outbreaks. If you went to Washington County outside of Houston, it's got, I don't know, 8 times what I just described for Houston, something like that in terms of deaths per 100,000, because they've had a couple of very large nursing home breakouts in a relatively small community. So, 25 deaths or 30, whatever it is, ends up, on a per 100,000 basis being a high number. So you have to look at all the numbers with a grain of salt. But I think that would be my guidance. I'm happy to take a look at that and chat with anybody or shoot me an email if you had some specific questions, but I just don't know those areas off the top of my head.
I think some of the people in the chat room are sharing some sites, particularly the New York Times site you just referenced. So people who are looking for more data can go there. Let me give you this question. We're in a small town church in East Texas. We gave congregants the choice to wear a mask previously. Should we begin to either ask people to wear masks or as they enter or leave worship, or should we begin asking people to wear masks for the entire worship service?
I would strongly urge that wherever you are, have people wear a mask. If I look at what we do as physicians and nurses and clinicians to keep our patients safe and keep each other safe, we uniformly wear masks throughout the institution. I can tell you throughout this pandemic, we have not seen large amounts of spread within our walls. It's because people are doing the right things. I firmly believe that there are safe practices that can happen. Masking is enormous. The bottom line is you can trap most particles and they don't go someplace. If I cough or sneeze or I get a little too close to you and I'm kind of raising my voice and I know there's some particles there, if you're 2 feet out, some of those particles are getting inhaled by you. If I wear a mask, the proportion of that declines dramatically. We think it's tough to get a really good study, but it may be 75 to 80% decrease in risk. There's one study that came out very recently. I'm trying to remember which journal it was in, and I can't remember off the top of my head, but it did kind of a multivariate analysis against a lot of the different things that have been implemented. Its conclusion was the most effective thing out there. I mean, not the full shutdown, but for areas where people are together is masking. So my strong recommendation, unfortunately it's a political issue and I get that y'all are going to deal with people, with some opinions about that. But my strong medical advice is it's such a small price to pay. Yes, it's a little bit warm, but I mean, I've spent countless hours of my life wearing a mask, through medical school and through residency and taking care of patients and, being in an operating room for hours on end. You get used to it. I mean, it's just like anything else. And people have gotten used to it. I see so many areas where people just do a perfect job. There's no reason that for an hour-long service that people can't come in, walk in, be with each other, keep that mask on the entire time and leave. And I think that's by far the safest way to handle it.
What about taking people's temperatures before they come in the building? Is that something that ought to be done, or is that sort of over the top?
It can be done. It's probably a little over the top. I mean, so we do it at the hospital, but of course we're protecting vulnerable people who are, people who are vulnerable, we're saying you need to come to the hospital so we can care for you. Don't avoid us. So we know we have lots of people who have vulnerabilities within our walls. So we're extra cautious, but I can tell you we've temperature screened thousands and thousands and thousands of people, probably tens of thousands at this point. We don't get a lot of positives, to be honest. It sets a tone as much as anything. It's a time where we are able to ask some questions and quizzes and kind of, check on people and make sure they're wearing a mask and all those things. We're trying to automate some of it because, we used some staff that were kind of, in labor pool because their areas were shut down. And now, of course, as the hospital came back up there, they need to be working at their home units and their home places. In a church setting, again, I guess what I'd say is if I were leading that congregation, I'd say to everybody, hey, we got to have a social compact that if there's any doubt, you stay home. And, that's the strong compact. And I probably wouldn't put in a quiz, questionnaire, temperature screen. You can, don't get me wrong, but I don't think you're going to find that to, yield that many people that you turn away or anything like that.
What are the rationale for getting tested for COVID or for antibodies? Under what circumstances should somebody go to get a test?
Sure. So two kinds of tests, right? There's the PCR, so that's the swab in the back of your nasopharynx. Increasingly, we hope there'll be some more nasal swabs because it's just a little more comfortable. I mean, it's uncomfortable. It's not that bad, okay? It's not like everybody's favorite thing, but most of us who've had anything healthcare, it's very low in the scheme of discomforts. But they will put a little swab kind of through your nose all the way to the back of your throat a little bit. That looks for the genetic material of the virus. So it tells us, is genetic material of the virus present? I say it that way because it doesn't distinguish between an alive virus and a dead virus. So when you see some of the noise about, well, I tested positive 3 weeks later and I was negative before, what we don't really fully understand is that live virus, or is that just some fragments that are left? And the thing is very, very, when it's there, it finds it. So that's for I would say 2 times that people should be tested generally in your population. I'll give you a third, sometimes others. One is clearly if you have symptoms. Doctor orders it, let's get you tested, let's find out if you have it. It's probably about 75 to 80% sensitive, meaning take 100 people with it, it will pick up, let's say 75 or 80, but it will give you a false negative on 20. The reason for that is it's a difficult sample. It's uncomfortable. It's hard to really get it. The virus may sometimes, it binds receptors in the lungs, so it's possible it's not as much back there and more down below. So we've all dealt with situations. I had a patient in my own practice came in, we admitted him. He had an X-ray CT that looked like it. We knew he had it. We could never figure out that he was positive. And 4 weeks later, after I'd sent him home, I did the antibodies, and sure enough, he had it. So anyway, that's number 1 for the PCRs if you're symptomatic. Number 2 is if you are exposed. And so if you have a known exposure, usually we use close by exposure for some meaningful period of time. So not a glancing exposure, but 5, 10, 15 minutes. It's a discussion with your clinician. It's when do you test? Usually you wait. Usually you say stay home. Let's not have you cause more problems potentially. But it's too soon to test you if you call me the next morning. And let me give you a couple days because you'll be more likely to be positive. So sometimes in asymptomatic exposed people, we will use that test as well. That's what for most of the world, that's where they're going to be tested. The third is in some surveillance settings. So we do surveillance on staff to try and avoid having an asymptomatic staff member. Of course, masks are a big, huge protection to that, but nonetheless, we want to avoid that. So we do some additional surveillance. But in your setting, that's not something you would do. There are some meat packing plants and things where this has been a real problem. Certainly nursing homes, prisons, other places like that, people are using surveillance techniques, but that's not a technique y'all need to use. Then the other end of the spectrum is the antibody testing. Antibody testing generally does not tell you, yes, you have the disease now. It tells you you had the disease before. Now, I say generally because about a few days in, you may start to be positive, but it's really not the diagnostic test that we use. There are 2 broad kinds. There are what are called a lateral flow assay, which is, think of a pregnancy test, right? You get the plastic strip, and there, in that plastic strip, there is a paper that's basically, got a reagent that will react if the right, in that case, hormone is present when you're doing a pregnancy test. And that's the way those work. They, especially after the FDA got so much criticism around how they handled the first round of testing, PCR, which is a challenge. They let a ton of these things in, and then the scientific community started looking at them and said, hold on, these things don't work. And most of them are lousy. So I really don't recommend you use those. There's a couple exceptions. We have a couple we might use in occasional settings, but we've really validated them. But by and large, I wouldn't use them. The reason is the sensitivity is not too bad. So in other words, giving you a true positive isn't too bad. So if you have 100 people with it, they're going to do a pretty good job telling you whether you have it, but they have a very poor what's called specificity. But just think of that as the false positive rate. So they, in best case scenario, they might have 95 to 99% specificity, which means think of it as a false positivity rate, which sounds pretty good until you look at a disease that has 3% of the population has it. So if you take 10,000 people, and we know 300 have it because that's 3%, and you have a specificity of 95%, you're going to do 10,000 tests. You know that 500, and therefore 9,700 people don't have the disease. you're going to get 5% of those people. We'll just call it 5,000, 500 for easy math. You're going to get 500 false negative or false positives. You have 300 true positives, and you'll get 95% of them. So we'll just call it 300. You'll have 1.5 to 2 times as many false positives as you do true positives. So it becomes almost impossible to understand and use. So the other type of test, all of the sophisticated labs, whether you're talking a hospital-based lab, LabCorp, Quest, we all have much more sophisticated assays. They typically quote, the FDA is saying 100% specificity, at least 99.8% specificity. So when you have a positive, you're probably 95% sure it's a positive. The real setting for using that is understanding somebody who has had the disease. So, when do we need to know that, right? So my patient that I described who came in, he was sick, he went home, we said, boy, he sure had it, but we never got the test. It was pretty useful to know a month later that he had the disease, both for me to learn and our team to learn about the presentations, for him though to know that, hey, I did have that and my hospitalization was for that. And we know he's at least at some reduced risk in the future. For most people though, it's more of a curiosity or a relief, right? So, boy, I felt lousy back in March, but I didn't get tested. I wasn't sick enough to go to the hospital. Back then, there weren't many tests. I wonder if I had it. And it's perfectly fine. Your physicians can order that. There's tons of testing capacity. It's very easy to do because it's a, small blood draw. But for most people, honestly, the antibody test is not that useful. The biggest use is for doing prevalence studies and for doing, epidemiologic studies. So for the scientists to do it, maybe some work settings at some point, like for a hospital where we have all this high risk, where at some point we might want to identify people who've had it that we didn't know had it at some point. Because, at some point you put them on the COVID unit if they've had COVID and those kinds of activities. But for most settings, not something you're gonna use that much.
What about resuming children's and youth ministries, and especially preschools? What's our
children? The really good news is children don't get sick, by and large. Texas Children's, has a few patients in-house at any given time, maybe 10 at max. And of course, I think you have to talk to them, but my understanding is many of those are kids who have underlying health conditions, so they're at a higher risk. That's the good news. There's a rare condition, and it still looks to be pretty rare, but it is existent, which is kind of an inflammatory syndrome that's similar to something called Kawasaki syndrome that, kids can get very sick from and die, but it is really rare. So the good news is that's not a group you have to worry about, having the life of a child at risk by putting them back together. They, of course, can spread that to their family members. I've never met a 4-year-old who knows how to socially distance, so you get into issues, with the younger children. Older kids, for sure, you are safe. If you want to have some things, smaller numbers still, socially distanced, they should wear their masks. They need to be taught and educated, about what they're doing. They don't need to be sharing all the same play equipment and things, but to go in for a Sunday school lesson or things, there's probably some ways you could do that safely in my mind, similar to how you'd handle, an adult, with twist, of course, but an adult. The little kids, it's a tough one, right? Because we have many employees who have their children in daycare. How else would they work? Many families who want to do that. I think there are ways to do that. You're going to have, I would be putting, younger staff there. And I would be acknowledging the fact, you have to have a kid with a runny nose or, that's not the most symptomatic thing, but still, if a child's got any symptoms at all, they need to not be there. And families need to keep them out. And if you do need some daycare, you need to figure out some ways to really minimize the normal 3-4-year-old behaviors that are going to happen. So, smaller groups, find some games you can play, educate them, without scaring them, find some fun games that involve not touching each other and using the same stuff. I mean, there are probably some creative things that child life specialists and teachers and Sunday school teachers, daycares that are open now could advise you all on for sure.
I've had a couple questions submitted asking if being outdoor for worship lowers risk factors at all, would allow for singing or other things, or do we still need masks even in an outdoor environment?
So I think most certainly outdoors is safer than indoors. We're not seeing many reports of widespread transmission events outside. couple caveats. We know there was a 60,000 person march, with not nearly a majority of those individuals wearing masks who were there. I saw some other protests where everybody was masked in the medical center. Those gave me a lot more comfort. Clearly there was some spread there. I mean, we know there was. So I'm not saying outside is fully safe, but the good news is the prevailing wind currents and other things tend to lift things up. You don't have a roof, you don't have a circulation system. So outdoors is very safe. You still should obey and follow social distance. If you're going to have people close together, I would still mask them. If you're going to put a large group of people together, I would still try to go for 6 feet. At 6 feet, I'm conservative. I'd still prefer people wear a mask, but if you got everybody 6 feet outside, coming and going masking, but if you wanted to have some masks off during that, that's probably okay. I'm conservative. Let me be honest. I would prefer that everybody wore a mask, and I'd still prefer that was not an ultra large gathering. But I don't think those are going to be your highest risk settings for communicating the disease.
Marc, I want to thank you for this conversation. There are questions that came in that we don't have time to get to, and we have recorded this conversation. It will be posted on our conference website. And for many of the United Methodists on the call, we will send you a notice about exactly what the link would be. But Marc, you are an incredible leader for our community. Grateful to have you as a partner with the United Methodist Church, and grateful for all the work that Methodist Hospital is doing. So thank you for taking.
May I jump in one thing? If I may?
Okay.
And Bishop, first off, I want to thank Bishop again for all of your leadership and for all of your op-eds and everything else. We even authored one together. You did the work. I just put my name on it, but you've really provided tremendous leadership, and I appreciate that because it's helped get the message out. And that's a good segue to kind of my call to action for the group here. I mean, particularly those of you in the greater Houston area, this is a tough time. It's an important time for us. We want to avoid a shutdown. I'm not confident that we can definitely avoid that. I'm an optimist, and I think if we rally together, we can, but it requires everyone in the community doing this. So your voices are so amazingly important. Your reach just directly of who you will preach to in a couple of days, and obviously other times as well, but Sunday's just a couple of days away, is thousands and thousands and thousands and thousands of people virtually, I think mostly, but in person as well. You can really help spread the word. I've seen the bishop talk about God's love and really loving each other and really wearing a mask, protecting each other's, us loving each other and doing what Christ really, expects of us and modeled for all of us. So please help us with that, because I do think we are at a very important time in our history, and we really want to avoid having things get out of control over the next 2, 3, 4 weeks, and potentially having the virus even determined for us, not our political leaders, whether we have to take major financial and economic and social sacrifices again. And there's a lot of harm in all of those realms and in the health realm with shutdowns. It hurts everybody. It hurts the socioeconomically vulnerable even more. It hurts frontline hourly workers far more than it hurts salaried workers. It cuts, against race, against socioeconomic status. It exacerbates so many things. It exacerbates health issues when people avoid hospitals, and it of course exacerbates kind of the overall economic health of our region. So we can be all in this together, but we really, y'all help so much cut through the clutter and the noise that's coming from both ends of the political spectrum in saying, there are right evidence-based things to do that the clinical leaders are asking us to do, and together we can do this. So I appreciate your helping us with that message, because y'all are critically important. So thank you.
Well, Marc, we are certainly happy to come alongside you and take the scientific and medical judgments that you have so freely shared with us and add to it our community leadership. Friends, let me just say to any United Methodists who are viewing this, Your bishop, at least, is strongly encouraging you to get people to do the right things, to practice the social hygiene, the social distancing and the personal hygiene questions. I'm also giving you a strong recommendation that let's not move forward to further reopening for the next several weeks. I think it's time to refocus on being the best we can possibly be. This really is about loving our neighbor. It really is about being community leaders. Let's do everything we can to slow this virus down and get back to a flattened curve. Marc, thank you for the time.
Thank you.
Friends, thank you for joining this call. God bless you.
Thank you. Bye-bye, everybody.
Bye.